Okay, the management and treatment of CHD. Remember, in this lecture, we're really going to focus on how to rule out an MI. In small groups, when Chelsea goes over the debrief for the first case, she's going to talk about the management of the patient once you diagnose an MI, which obviously is very important, but at that point, we kind of, you see a positive EKG and you see a positive enzymes, you kind of pass that on. So it's not as difficult. This is the tough thing, right? This is the tricky part where, imagine you're sitting there in the ER and a patient comes with chest pain, and it's up to you whether or not this patient gets more care or you get to watch them for a little bit and they go home. And it's not easy, so we've really got to understand this. So now we're going to go back to categorizing our coronary heart disease or coronary artery diseases into the is it an emergency or not, right? It's less based on the pathology on what we do. It's more on whether or not we can identify this thing as an emergency or not. So if you can identify something as stable angina, well, then it's not an emergency and that patient can follow up later with their family practice doc. If you declared an emergency, now it's an acute coronary syndrome, and now you have to deal with it now, okay? So those are STEMIs, NSTEMIs, and unstable angina. I think it's easy to understand the difference between a STEMI and an NSTEMI, but how do we differentiate between stable angina and the other acute coronary syndromes? And how do we differentiate between unstable angina and NSTEMIs and STEMIs? And that's what we're going to talk about. Again, to reiterate, the basic thing that we're going to be talking today is once you identify a patient with ACS, now you're on a different route, right? Patients can be staying in the ER or in the hospital admitted, and something's going to happen with that patient, generally with cardiology. So ACS, you got to do something. If you're certain that the patient just has stable angina, then it may be okay to just follow them up for observation in the ER and then for outpatient care afterward. So discharge and follow up with their PCP within 48 hours. And that's what we're going to talk about. So I hope you guys still remember this chart from when we looked at it in EKGs. And really it's, again, just to show us what the difference is between the three acute coronary syndromes, unstable angina, NSTEMI, and STEMI, versus our stable angina. So everything's got chest pain. You definitely want to consider morphine, oxygen, nitroglycerin, and aspirin for patients that have all of these things. We can still provide relief to patients with MON. And then here's where the difference is. Right? If you diagnose one of those bottom three things, then that patient's going to be automatically admitted for an ACS route for a type of treatments. Which of these have EKG changes? Most likely NSTEMIs and STEMIs. So if you have an EKG change, well, then you most likely have an infarction, right? If you don't have an EKG change, well, then you possibly have ischemia. The enzymes, again, tell you the same thing. Do you have a troponin increase? If you do, then you're in infarction land, and if you're not, then you're dealing with stable or unstable angina. The ST elevations is what tells us the difference between NSTEMIs and STEMIs, of course. And then, the whole thing about a cath lab. Obviously, you're definitely going to be going to get some sort of percutaneous or coronary intervention with a STEMI. With an NSTEMI, if you diagnose with an NSTEMI, maybe they don't at that time, but they could progress to a STEMI. That's why it says no, but possibly. And the same thing with the unstable angina. So if you diagnose someone with unstable angina, they still have the opportunity to progress into NSTEMI and STEMI, which is why all three of these really require much more careful observation and probably a hospital admit. Again, how do we become sure about it? How do we know when we have an ACS? Positive troponins, positive EKG. Well, then how are we sure we have stable angina? That's what we're going to talk about now. So who gets an EKG in the ER? Pretty much anyone with chest pain is going to get an EKG. It says here any patient over 30, but I think any patient that comes in complaining of chest pain is probably going to get an EKG. These recommendations are kind of like the automatic things that are made. These are the recommendations basically for guidelines at a hospital before you have any interaction with a health provider. So if a patient comes in, they're over 30 and they're saying they have chest pain, they're going to get an EKG. Any patients over 50, if they have dyspnea, altered mental status, upper extremity pain, syncope or weakness, they're going to get an EKG. Okay, obviously if they have chest pain, they're going to get an EKG, but even if they don't and they just have these symptoms, they're going to get an EKG. Any patient over 80 that has abdominal pain, nausea, or vomiting, they're going to get an EKG too. And this doesn't even include patients like our atypical patients, where you might be worried of someone with diabetes that has nausea, right? A patient that comes in with diabetes and nausea, sure, it could be gastroparesis, but it might be an MI and you're not going to know. It's obviously it's really easy. It's a non-invasive test to do, so we tend to have lower thresholds for EKGs. I've already briefly talked about a patient being negative for troponins. Like we said before, troponins don't really become positive until 3 to 6 hours after the insult starts. The same thing with EKGs, they may be negative too. So basically what it says here, in eventual MIs confirmed patients, the initial EKG is non-diagnostic in almost half of the patients, right? Patient comes in with chest pain, you put an EKG on them, almost half of the time it's non-diagnostic in patients that eventually will be diagnosed with an MI. I'm not talking about patients who come in period with chest pain, the ones that actually end up being diagnosed with an MI. Half of the time they don't have a positive EKG with their first one. And 20% of those patients that eventually have been confirmed as having an MI, some of them even come back normal EKGs. So you definitely can't trust that a patient that has an initial EKG that's normal or non-diagnostic doesn't mean that they're okay. So that's why, again, why we do serial EKGs every 15 to 30 minutes when patients come in. So again, the very basics of this. If the patient has an acute coronary syndrome, they're going to do something. These specifics we'll talk about in small groups. If the patient doesn't have an ACS, then you've got to figure out what they have. And if you can find something diagnostically or positive with pneumonia or GERD, then you treat appropriately and move on in that direction. But it's this third scenario that's tricky, and which is what's going to happen a lot with patients, right? Imagine this. Patients that come into the ER don't generally have an MI with chest pain. And they don't generally have something else either. What you're doing basically is you're assessing the patient to see if whether or not the chest pain they're having is cardiovascular, and if it's severe enough that they need to stay into the hospital, or if they can go home. It's not easy, so there's a lot of different nuance here. We'll go through it. So what we're talking about is assessment of a low or intermediate risk of acute coronary syndrome in the ER. So here's the algorithm that we're going to be following as we talk about treating patients or managing patients that are of low or intermediate risk for acute coronary syndrome. You don't get to this algorithm if the patient has a positive EKG or a positive troponin. If those things are positive already, well then you're going to send to an ACS. This is to figure out patients where you have some difficulty. So this is where we start. So first, assess if they are high risk or if they're at low intermediate risk. Okay? If the patient is deemed to be high risk, that's where you assume an ACS. even if you don't have the EKG and the troponin results left, you can assume ACS and at that point do something. If you can't deem them high risk from this, then they're low or intermediate, and then you continue on with the algorithm. And whether or not they're high risk or low risk is based on their heart score. Okay, I have it here that if you have 4 or more, then you assume ACS, and the next slide is where we're going to talk about what the heart score is. So how do we score it? Anything greater than 3 points or 4 points and above is a high-risk patient. So heart, history, EKG, age, risk factors, and troponins. I think it's pretty easy to understand the EKG scorings, the age scorings, the risk factor scorings, and the troponin scorings, but how do you score the history as highly suspicious, moderately suspicious, or slightly suspicious? Well, it really is just that. If someone comes in and they say they're doing a lot of heavy lifting outside or the classic shoveling snow, well, that's very highly suspicious. If they're doing exercise, they start having chest pain, and they've had this chest pain before related to exercise, and they've had a heart attack before, and they know that this is what it feels like. Those are all highly suspicious things, okay? There's no specific criteria on what is highly suspicious or moderately suspicious. It's really based on our subjective view on what it is, but there are the points. Anything greater than 3 points, you're going to assume it's an ACS and go for it. You can see EKGs and troponins are included on this too. So the practical use for this, again, it's not for the high-risk patients. Those are easy. It's to help with the assessment of low-risk patients. When can you feel safe assuming a non-acute coronary syndrome patient? Also, note the places here where judgment is necessary, right? If everything else is 0 points, but they have an ST elevation, they might only score 2. But that doesn't mean that they're okay to go home, right? So if someone has everything else is normal, but they've got 2 points just because of troponin, it doesn't mean they failed the heart score, right? That means you're assuming ACS still because it's troponins. So when is it useful? So here's an example. You've got someone that you're moderately suspicious of, right? They sound like they're talking about stable angina, right? Where it's angina that's predictable. It happens when they are working. You know, some reasoning to think that they might have a heart attack. They've got a couple risk factors, so there's another point, and they have a left bundle branch block, which is a non-specific repolarization disturbance. So there's 1 point right there. So 1 point, 1 point, 1 point. There's 3 points there already. Okay, and let's assume that they're a young patient, so they're 40. Here, it's very tricky because they tell you all those things might lead you to believe that this patient has an acute coronary syndrome. But based on this heart score, it would suggest that they're low to intermediate. Okay, so you don't want to necessarily go all the way to ACS on a patient like that. You want to wait either for your troponins and move from there. So the next part is, does the patient have any evidence of ischemia? So they have ongoing chest pain, even though we've given them, oxygen and nitroglycerin and aspirin. Do they still have chest pain? Do they have unstable vital signs like a high blood pressure or low blood pressure? Do they have signs of ischemia on EKG? Well, then there you're going to assume an ACS. You're going to go the route of a PCI or something. Okay. Again, this is to just help you not rule out patients that actually have an ACS, but they just don't meet the scores because of the heart scores. Okay. Step 3 then is get cardiac enzymes and then repeat an EKG and get a chest x-ray, right? So the tricky thing with this is that, we've made this into steps 1, 2, and 3, but in most hospitals, all these 3 steps are put in together and they're done before you even see the patient, right? Cardiac and EKGs are generally done right away. And in some places, cardiac enzymes go along with that. There are some places where the health provider still has to order the first set of cardiac enzymes, but a lot of people have their algorithms so that even before the health provider sees them, the cardiac enzymes are drawn already. So that can be a little bit confusing here, but this is the stepwise portion of this. As we continue on, here's where this algorithm is useful, okay? If you get the troponins and they're not elevated, then you transfer the patient to observation and you get the second round of troponins in 3 hours, right? So that's where we work with the issue of patients that have normal troponins, but it could just because we're seeing them early and their troponins haven't changed yet, okay? So troponins haven't changed, send them to observation, get your second set, okay? Remember that the initial set of troponins are normal or inconclusive, so you don't send someone home just because they've got normal troponins at this point. The easy part of this algorithm, if they're elevated, send them off, right? That's easy. Now, what do we do during this observation phase, okay? First off, make sure you're continuing with MONA treatment or start it if it hasn't been started yet, right? Morphine, oxygen, nitroglycerin, and aspirin. And make sure that you get that those second orders of troponins ordered at 3 hours, right? They can't just do them right away. They have to be at 3 hours after the first set, okay? If they're elevated at the second set, well, then obviously you do something about it. If they're not elevated, now we go back to that heart score and we use something called the heart pathway to really figure out what are we going to do with this patient at this point. Because this is where it's tricky, right? Just because a patient has 2 sets of non-elevated troponins doesn't mean that they're just okay. You still have to do some more assessment and testing to see what needs to be done with this patient. And that's why this is more difficult. Like I said, it's easy to do something when you have a diagnosable MI with troponins because, again, you're going to go the ACS pathway. Here, you've got to figure out what to do on your own. So if we've already assessed the heart score at the beginning, it's not like we have to do a different score here. The heart pathway is just what we do with that score after the patient has 2 inconclusive or normal troponins and no real signs of ischemia, okay? Right? If we have ongoing ischemia, that's ACS again. But this is a patient that came in with chest pain. You gave them a little bit of morphine, oxygen, nitrogen, aspirin, and the pain went away, but you're still concerned that they might still have an MI, even though they have normal troponins because of their risk factors and age and things like that. So the heart pathway is just what happens to the heart score when you get 2 negative troponins, okay? It's the same score as the initial evaluation. So this helps evaluate a patient at low risk or at high risk for ACS at this point in the ER. So the patients are generally still in observation, but you're just not sure if you want to discharge them yet. If the score is still low, okay, then they have less than a 2% chance of having a major adverse cardiac event in 30 days, okay? At this point, they can be discharged. Some people do a repeat troponin level again, so this would be a 3rd troponin and they can go home. There are some places that are okay with having a low score at this point. If they have a low heart score and 2 negatives, then they can go home. Some places will want a 3rd. If they come in with 2, right, the initial troponins and then the troponins at 3 hours and they're still negative, patients at this point who have a high heart score, well, they have a 12 to 65% chance for a major adverse cardiac event in 30 days. So at this point, consult cardiology and figure out what they would prefer. And there's general things on what people like to do here, but definitely cardiology is going to be on board for this one. So real quickly on the side of these scores, some of you might be thinking, gosh, I worked in the ER and I've never heard of these heart scores, or some of you may be familiar with them. These scores, they're EBM derived, they're evidence-based medicine derived, and they help health providers with basically with intuition. Okay, so throughout your education at ISU and beyond, you come across all of these different scores, heart scores, Wells criteria, lots of different scores that we always use to try and help with our clinical intuition. And these things are made from statistics, right? It's not just people's general opinions. They know that if these people have a combination of risk factors and ages and symptoms, that this tends to be the outcome. If it's this set of symptoms and ages and risk factors, then it's this outcome. So that's how they're made. Do you have to use them? Do you have to document that you've used them? No, you don't have to do anything. Now, you may work for a health network that requires you to put in the Wells score to make sure that you've calculated it, but you may not work for a health system that does that. It really depends. So again, they help with clinical intuition, but it should not replace it. Remember when we were looking at the heart score, you could definitely add up or make up scenarios where the score would be 2, but it was an obvious ACS situation. So as with any recommendation, they are just recommendations. They're not legally binding or applicable. Again, it depends on whether or not you work for a health system that requires you to do those things. Okay, so now we're in that situation where we've got 2 normal or inconclusive troponins, and based on the heart score, we figure out what we can do. Okay, if the heart score is low, if it's 3 or less, then we can consider discharging the patient, or we have to go and consider other diagnoses if there's symptoms that would suggest that. That's, again, kind of an easier thing, right? It's if you remember the heart score, it's kind of difficult to get very low on there. So it's a pretty good way to feel comfortable with discharging a patient after they have no EKG changes and they've got a normal, 2 normal troponins. Okay, so you can consider discharge as long as their heart scores are low. Where it gets tricky again is this whole section right here, right? Greater than 3, but you still don't have any positive troponins. So obviously another thing to do here is you can get a 3rd set of troponins at this point to see if they turn positive, but if they don't become positive again, you still have to figure out what to do. So we're going to be sending the patient for non-invasive or stress imaging, okay? And so based on this, we can at least determine whether or not the patient needs to be managed as an ACS, or if we can discharge them, okay? Throughout this whole process, non-invasive or stress imaging, it really is done with in coordination with your cardiology team. So you won't have to do this on your own as an ERPA. And really, when we cover this, it's really going to be a primer on these techniques. We're not going to be experts in this at all. It's just something we want to give you guys some exposure to. So kind of what I talked about already, but what are we going to do now? ACS management, anytime you get down to that part of the algorithm, we'll talk about that in small groups. As far as non-invasive evaluations, it's for patients that don't obviously have ACS, but who obviously don't have, right? They're not obviously not ACS, right? If their heart score is still high, well, then they still could be having an acute coronary syndrome. So something is cardiac, but how bad is it? So you assume stable angina and either discharge if their patient heart score is less than or equal to 3, or send them for non-invasive evaluation if it's greater than 3. And then through this whole process, as you're going through your differentials, getting chest x-rays, asking the patient about other issues, then you've got to fix those things if you find them. So yeah, we're going to talk about non-invasive evaluation. It's tricky. There's a lot of different ways, and this is a really rapidly growing part of medicine right now. So, this isn't meant to be an end-all be-all at all. It's just meant to introduce you to the concept. So non-invasive evaluation can be really split up into two major categories. We have stress testing or provocative testing, and then we have rest imaging. When we have stress testing, we either stress the patient out or stress the heart out by doing actual exercise testing, or we can induce that stress with pharmacologic ways. Rest imaging is either done with nucleotide imaging, or you can do it with echocardiograms or with CT angiography. So how do we select between stress testing and non-stress testing? Well, the main way is if the patient is still having symptoms, then don't do any stress testing. Okay? That's basically it. If the patient is having symptoms, well, then you're not going to go into that stress testing, and now we're going to be deciding between the nuclear medicine echocardiogram or CT angiography. If the patient is not hemodynamically stable, well, then we have to go to CT angiography. Okay, and so signs of hemodynamic instability would be a low blood pressure, or the patient's going through shock or altered mental status. And it's basically just a CT with contrast of the blood vessels. If the patient is having symptoms, then the preferred methods are the nuclear medicine or the echocardiogram, but the patient has to be hemodynamically stable for that. Okay? If they are, then RMPI or echo is preferred. For an echo, it just looks the cardiac wall for movement defects, right? So you can see the movements back and forth on the colors. If there's not any movement where there should be, well, then that would suggest that there's dead tissue there. Obviously, I'm not an expert in that, and we don't expect we don't expect you as students to be able to identify or read a good echocardiogram either. That's definitely an advanced topic. One of the things that I think students have a misinterpretation of why we do stress testing versus non-stress testing is, well, of course, the symptoms, that makes sense. But it's not because we want to keep the patient from being healthy and that we're worried about causing stress. I mean, actually, the whole point is we have to see symptoms. If we don't see symptoms, then we're probably not going to see as much of the signs of ischemia or infarction on the heart. So if the patient isn't having symptoms, then we do a stress test to induce those symptoms. Okay? So basically, if there's no symptoms, how can we see a defect, right? Of course, with things like an infarct, well then, yes, you're going to see a defect. But if a patient's having an infarct, well then they're having an ACS and they're not in this non-invasive route. Remember, this is in for a patient that didn't have any damage to their heart, right? They had normal troponins and they didn't have any EKG changes. So we're trying to figure out if more stress is then going to cause a problem. So we're almost kind of like inducing an ACS in a safe place. So stress testing recreates that oxygen demand deficit, and it tests the severity of the deficiency. And so it's also a way that we can see it, right? If patients don't have EKG or enzyme evidence of acute coronary syndrome, well then how can we tell if they actually have heart disease or not unless we, like I said, unless we stress it. So stress testing, exercise or with medications. Stress testing is for patients where the symptoms are resolved. So first, make sure that the symptoms have truly resolved. You don't want to cause an issue with patients that are still having chest pain and then stress them out even more. That's no bueno either. So then how do you tell the difference, or how do you make the decision between exercise or medication-induced stress? Well, it's, can the patient exercise, right? If the patient can exercise, then you give them a stress test. But if they have a problem, if they can't exercise maximally because of a disability or the inability, well, then they can't have symptoms. And if they can't have symptoms, you can't detect any deficiency, okay? Okay, so assuming that the patient can exercise maximally, that means they're going to go through a stress test. And what you're looking for is the point at which there is ischemia and symptoms, okay? So on an EKG, you generally look for horizontal or downsloping ST depression, right? You're not pushing the patient and then seeing the depressions and then pushing them more until you see elevations, right? We're not trying to cause tissue death. We're just trying to cause oxygen deficiency and tissue damage. And maybe not even damage. Like I said, we're looking for mainly ischemia. So we look for horizontal or downsloping ST depression. And so the prognosis of the patient is based on how much exercise they could do before the ST segment depressions show up, right? And so, again, we're not going to go into the specifics of how long that is, but you can see that someone that is only on the treadmill for a little bit and can't really do much exercise before they have ST segment depressions, that's no good. There are under some systems or instances where patients don't necessarily need to go through maximal exercise testing, which means, again, they have to have the point of ischemia and ST depression. If the patient is also having a concurrent imaging with an echo or an RMPI, well then, since those are more detailed tests, you can actually have patients undergo exercise that's sub-maximal but still get some results from it. So what if the patient can't exercise? Well, then you need to stress them out with pharmacologic ways. So this is always done with imaging on top. It's not just an EKG, so you do it with echo or an RMPI. Here are some of the combinations of drugs and imaging that happens. I'm not going to test you on these things. I think it's just a good thing to be, again, exposed to. So vasodilators like adenosine and dipyridamole and regadenoson, those tend to be used with the nuclear medicine, whereas positive inotropes like dobutamine tend to be used with echocardiogram. These are just the common combos that are out there. Depending on your health provider or the place you're working at, you may see different ones, but just so you have some familiarity with them. Okay, so that's the end of the lecture, and it's a big lecture. I think the first half of it, when we just talk about the symptoms and clinical manifestations, I think those are things that we either outright know already or have some intuitive sense of those things. But as we go into the management and treatment, things get a little bit more complicated, and even for those of us that have experience with those things as scribes or being in the ER, we may not know all of the decision-making points that go into these things. For those of you, that's awesome. Then this should be review, and you probably see some differences in ways that health providers practice, but that's medicine, right? Everyone practices a little bit differently, but that's basically it. If you guys have any questions, obviously feel free to reach out to me, and good luck, guys.